of course, the Prepare Tiger team. Thank you very much. And as always, thank you for everyone joining us today. We are at 52 right now, and I see that a lot of people are introducing themselves on the chat. Welcome everyone from all across the nation, and we'll get started. So lest I remind you of NAC's strategic pillars, and we do believe that informatics and data do support all 6 of these. We've been around for more than 50 years now, so thank you again for joining us and attending our webinars and educational seminars. What you're seeing here is a survey that was done a while ago, describing what they would like to do with their Prepare data. And I noted 2 things here, the one in the middle and the one on the right. They would want their vendors accountable for making workflows as easy as possible. And they also want to learn more how to use Prepare data to inform risk stratification models. So stuff like that. What we're going to be talking about today is really understanding, evaluating, and how to really look at your data, make them actionable, and all that good stuff. I'll start with this quote by Lord Kelvin. This guy is his other name is William Thompson. He said, when you can measure what you are speaking about and express it in numbers, you know something about it. So this guy is a prominent physicist and engineer from the 19th century. He's known for the development of the Kelvin temperature scale, if you recall in your science classes before. What you see in the middle here is the oval with data that says in it and has raw and stored values. This is kind of when you talk to some folks who use who have this concept of data, they think of these values. For example, in Prepare data, they're captured using a string of text, maybe a string of numbers in the back end, who knows? But data are in different formats in different ways, from security, metadata, all the way to PRAPARE data and associated data. I'd like to start this session by talking about language. You're seeing in this image, there are different ways of saying hello. In the same way, we know that Prepare is available mostly in English with translations, right? So what you're seeing now is a 2016 version of Prepare, just reminding you all of what it looks like. But I want you guys to focus on different areas or headings and the questions and the concepts that are represented by each of the questions in Prepare. So on the last slide, you saw those, again, saying hello in different languages. In the same way, Prepare is translated in different languages too. On the left, you're seeing the Spanish version. On the right, you're seeing a Korean version. And this is what the providers and maybe the patients, if you're letting the patients fill the Prepare form by themselves, this is generally what they see also in English. But what is not generally or easily understood is what's behind the scenes in your EMR or in your computer or in your software. Did you know that Prepare, the full questionnaire, is represented with standard machine codes in a terminology or controlled terminology called LOINC, L-O-I-N-C. You see their logo on the top left from Reagan Street, from Indianapolis, Indiana. And LOINC is used generally to identify the questions and the answers in Prepare. You're seeing it here on the left-hand side of the screen that the Prepare survey or assessment tool actually has one and a single LOINC code that represents the concept of, well, this is Prepare. And on the right-hand side, you'll see what is called a FIRE code in JSON or JavaScript object notation. This is what it looks like behind the scenes if you're going to represent it on what's called FIRE. And you may have heard FIRE in our other talks before. I'll put some arrows here that shows you which part of the code represents which part of Prepare. On the right, you'll see that, again, 93025 Prepare survey represented through LOINC represents the actual survey itself. Below it, you'll see that on the right-hand side in the bottom, bounded again by a red box, with the question, what is your housing status today? I do think the arrow was incorrect. I'm sorry about that. But generally, it points to 71802-3 under family and home. And then answering that question, what is your housing situation? Again, represented with 71802-3 loin code. You have also what's called an answer list, which is on the top right here, LL3, LL5350-5 is the answer value set for that specific question. And you'll see LA, those LA codes in bold on the right that I didn't highlight, but they're in bold. These are the answer codes for each of the available answers on the prepare assessment tool that represents that specific answer. And these are usually mapped to SDOH concepts in SNOMED CT and others. But I wanted to show this off really to show you how behind the scenes what is supporting, or what is the language that our software uses to talk to each other, right? You saw JSON earlier. What you're seeing now is an XML version of this. It's longer. It looks like a HTML code, but generally what I'm showing you is how this can be represented in the back end and how this information is exchanged through standards called, and in this case, FIRE standard in XML. Why do we talk about this? Why am I talking about standards and all of that stuff? I see a lot of quality people on the chat. No, if you start with really bad quality data, it's very difficult to really turn it into high quality data with no information on it. And that's why we wanted to support standards and show you just quickly the policies that support understanding your data in Prepare. So the 21st Century Cures Act, a lot of people know about this in 2016. It started, and I put here underlined which sections are important and are pertinent to Prepare, which is interoperability. It says here in the act that there should be adoption of standards and policies that enable data sharing. So you can ask the question, am I sharing my Prepare data? After I evaluate it? The second is that your EHR vendor should be meeting that specific standards to support that kind of data sharing. So regardless of whether or not you're in Epic or in Cerner or eClinicalWorks or NextGen, if they are certified health IT products, which they are in the United States, they should be meeting these interoperability standards so that on Epic, you should be able to share your SDOH data to any other EMR vendor using what's called application programming interfaces. And what's being mandated right now is what's called the FIRE API, which should be open since last December 2022 to all customers of EHR vendors. And a part of the 21st Century Cures Act supports what's called USCDI, or the United States Core Data for Interoperability. We are now in version 4, but it started in the year 2020, version 1. It establishes a minimum set or common set of health data elements essential for interoperability worldwide. In USCDI, it's separated in two things. One is called the data class, and one is called a data element. Data class is just a group of data elements. Again, it's a standard way to represent different concepts and different data elements. How does this relate to Prepare? Let's look at version 1 and version 2 of USCDI. Again, version 1 was 2020, version 2 was 2021. You'll notice highlighted here in this slide on the right-hand side that SDOH assessment is included as a data element in USCDI version 2. And in this also, it includes goals, health concerns, and interventions. I'm also showing USCDI version 3, and these were new data elements and classes included in version 3 in the year 2022, was coverage status. And you'll see I put an arrow over there pointing at a specific question on the Prepare 2016 version, question 12, what is your main insurance? And this maps specifically to these data elements on USCDI version 3. Why is this important? It's because of this, the 2023 ONC proposed rule, or commonly known as the HTI-1 proposed rule, which will be final by the end of this year, which mentions that all certified health IT products in the United States, also known as Epic, eClinicalWorks, Cerner, whatnot, are to adopt USCDI version 3 as the new dataset baseline across applicable certification criteria. Next, in the bottom here is to update transitions of care certification criteria to use CDI v3 and to add new data elements. It's basically saying all of these from version 2, version 1, and version 3, all of these data elements should adhere to specific standards in representing their data. All right, let's look at the handbook. Let's see what USCDI says. It says here that SDOH assessments like PRAPARE or any sort of structured or screening-based questionnaires for social determinants or drivers of health should adhere to the second column here, which are the applicable vocabulary standards. And it says here that they have to adhere to LOINC and SNOMED CT. And these are for both. If you go to the PRAPARE website, we have a 2022 data documentation and codification file, or crosswalk, which crosswalks PRAPARE questions and answers to specific SDOH domains. So feel free to check it out. We will be updating that soon. But aside from that, we're not just looking at assessments. On USCDI also looks at goals and interventions. You'll notice on the standards that apply for each of these are also on SNOMED CT or LOINC. And in interventions, they also included CPT, or current procedural terminology, and HCPCS. I want to just quickly go through the international standards, right? If for those quality people in the call, you know, they are included as multi-stakeholder influencers like the NQF, NCQA, and even NIST. And you have your standards development organizations above, and which organizations support which standard terminologies on the right. Just like ICD-10 is by WHO, CPT code is not free, but you have to pay AMA for that, and the rest are free. SNOMED CT, LOINC, RxNorm, and others. We'll quickly go through these because these are very common. This is pertinent to how you're coding or understanding your PRAPARE data. In the hopes that we move from the left, which is a nightmare, where there's a lot of crosswalking and translations happening because they are not systems are not adhering to the standard representation of questions and answers and concepts in the terminology standards that I showed you earlier, which are required. Quick glance at these terminologies from ICD-10 all the way to RxNorm. ICD-10 is for diagnosis and problem lists. As you will know, Z codes are included in ICD-10. CPT codes for billing codes and reimbursement. If you do CPT coding and you did a PRAPARE assessment, there's a CPT code related to that. And the problem right now, some people are saying that they are not reimbursing for SDOH, which we will get to at the end of the conversation, and please feel free to ask questions. LOINC, again, you saw that the PRAPARE assessment tool is on LOINC with only one code that represents the question and the answer for each of the parts of PRAPARE. SNOMED CT and RxNorm, and you'll see this in a bit. Let's go through this really quickly. ICD-10 started in the late 1500s. They just parish clerks, they wanted to see what people are dying from. They had funny names for croup and TB, like gripping in the guts and King's Evil. And eventually, epidemiologists really liked the idea of getting this information. And now we have ICD-10. The one we're using right now, ICD-10-CM, was published in 1992. So it's been a while. It's been around 30 years since it was published. And ICD-11 was just published around 4 years ago. Z coding, and this is quick anatomy of ICD-10 code. We are at the very bottom left for SDOH, Z00 to -Z99. And the more granular you are in an ICD-10 code, the more decimal places you go to the right of the period. Quick glance of the SDOH domains we know of from Z55 all the way down to Z65. And again, these are ICD-10 CM Z codes, and these map to specific SDOH domains on PRAPARE. So check out our crosswalk published on the PRAPARE website. Next, SNOMED CT, you will see a lot of these, and if you would notice earlier, SNOMED CT is one of the federally required standards for representing different concepts. And a lot of concepts on the PRAPARE questionnaire is on SNOMED CT, or best represented using SNOMED CT. This is a concept-oriented terminology. Again, all of these allow for machine readability. Again, our software don't speak English. They don't really know the context. They don't speak Spanish. They don't speak any of these languages. They know machine code, and that's what we're trying to do. We're standardizing using machine codes. SNOMED CT has a large to specific oriented ontology, meaning you can go from a parent all the way down to different children. The great thing about SNOMED CT, it is an ontology. What that means, there are different relationships for each concept. What you're seeing here is just a map of how a specific pneumonia is represented in SNOMED CT. You can get the organisms causing the disorder, a combination of these disorders, what is the pathological processes, what are the morphologies, or what are the finding sites for these. I want you to think about this in relation to, for example, a patient with SDOH concern. And we know that a lot of SDOH data, even if they filled out PRAPARE, some of them end up in the social history note or even the HPI, the history of presenting illness. You'll notice that we do have a lot of free text or unstructured notes recorded in our EHR for our patients. But what people don't know is that you can split up these unstructured notes and turn them into SNOMED CT concepts. Again, here on the front row here, the patient that is a 44-year-old with male, constant pain, lower back, moderate severity of about 3 weeks. All of those specific concepts can be represented using one code from SNOMED CT. And again, going back here, because we're talking about PRAPARE and evaluating your data, sexual orientation and gender identity, which I think is going to be already part of PRAPARE. If you will see here, these are the standards required in US core data for interoperability. And it mentions here that they should use SNOMED CT March 2023 release to represent sexual orientation and gender identity. Let's look at this next slide over here. And you will notice that on the top here, it says federally required SNOMED CT and HL7 null flavors. And available in the applicable value sets, and this I believe is for sexual orientation. Sexual orientation as a concept is represented using a specific LOIN code 76690-7, which means if we have all of the vendors adhering to this standard, which is again federally required, it's not specifically for LOINC, but if they did represent this using the LOIN code, then all databases of all EHR vendors, if you give them the LOIN code 76690-7, that should be able to pull up all data related to sexual orientation. Here on the left, you'll see that it says the requirements for sexual orientation, again, using SNOMED CT codes. You'll see on the bottom left here for lesbian, next straight, next bisexual, or have only one in a single one way of representing it in SNOMED CT. That's that specific code I put here on this slide. In the same way, there's what's called null flavors. If there's unknown, other, don't know, or chose not to disclose, there are different ways of representing that too. And you're seeing it in the bottom here is something straight from the PRAPARE questionnaire. Number 3 is sexual orientation. For queer and pansexual, there is a SNOMED CT code for that too, here in the bottom left, but they are not required currently still in the current requirements. For gender identity, again, that's question number 4 on PRAPARE. I'll put arrows over here starting from the top. Gender identity represented using one in a single LOIN code 76691-5, and representing gender identity also male and female, female to male, male to female trans, and genderqueer non-binary have again one in a single SNOMED CT code, and these are all federally required. So we've been talking about LOINC. What exactly is LOINC? So LOINC is an acronym for Logical Observation Identifiers, Names, and Codes. You will see this mostly in labs. So the easy way of remembering this is L, LOINC. L is for labs. But these are generally not just for laboratories. These are also for imaging tests, and in this case, for questionnaires. When I say questionnaires, not just PRAPARE, your depression screening, your EPDS, your PHQ-2 and PHQ-9 screening questionnaires and surveys are mostly all on LOINC. Again, which with one specific LOINC code to represent the questionnaire and different and single LOINC codes to representing each part of those questionnaires also. This is, again, free for use. In 1994, it's when it started, and this is federally required if you are participating or the AMR vendor is using or part of the Meaningful Use Program in the 21st Century Cures Act. These are one of the most common LOINC codes that you will see. Again, L stands for labs. In this case, these are labs. Creatinine with a 02160-0 ID on the top row here, with a specific class, which is chemistry. And the bottom, the next one here, hemoglobin. Again, the idea here is if you query your database 00718-7, that you should be able to pull all data related to hemoglobin in blood within the hematology and blood count class. Going back, I wanted to show you PRAPARE again. On the left column here are this, again, specific LOINC codes in the hierarchy. And the name here in the name column are the questions that's part of it, and with different data properties that's part of it. Again, as a reminder, SDOH assessments, which is PRAPARE, defined as screening questionnaires, that's structured evaluations for SDOH, requires LOINC and SNOMED CT. So please ask your vendor if they already have this mapped already for you guys. So when you query your database for one specific SDOH question for research, for example, you should be able to query it just by using a specific LOINC code or a SNOMED CT code. And I know we were talking about PRAPARE assessments, but we also always want to close the loop on SDOH concerns. Yes, you have used PRAPARE to identify a patient with an SDOH concern. You want to have goals for them, and you want to create interventions. And again, your attention should be on column 2. These are applicable standards that are required: SNOMED CT, LOINC, and then for interventions, CPT and HCPCS. Let's do an quick example of this. Here I highlighted question 1 and 2. Which is race and ethnicity on the PRAPARE questionnaire. What's happening behind the scenes then? This is the USCDI representation of a patient's race and ethnicity, which are federally required through, again, the HTI-1 proposed rule that requires USCDI version 3 standards. So for race, let's look at it here. It uses both standards, either the OMB 1997 race and ethnicity standard, or the CDC's race and ethnicity code set, or the CDC REC version 1.2. Again, federally required. Let's look at race. I have put an arrow here of race pointing to the table on the right. Those are the concept codes that are federally required from CDC's REC code set that represents these different races. So again, what does this mean? If you want, again, to look at all of your patients who are Asian, then you should be able to use that one specific code, 2028-9, and that should represent the concept of Asian race. And it shouldn't be free text. This should exist in your EMRs as a standard. If not, they should adhere to it based on the proposed rule that will be final. Same with ethnicity. You'll see I highlighted here in the bottom for Hispanic or Latino and not Hispanic or Latino are specific concept codes 2135-2 and 2186-5. And there are expansions of these value sets also. You'll see that race has a more granular value set that's on the CDC REC 1.2. Race, a detailed value set of race has 921 concepts, and you see an example of this on the very right. Similarly, for ethnicity, there is an expanded version of this with 43 concepts, and you'll see an example of this also right next to it on the bottom. So we want this because we want this new approach to approaching SDOH, right? We use the PRAPARE tool to do assessments. They have them mapped to an ICD-10 Z code. In this case, in the middle, this patient is experiencing homelessness and food insecurity, most probably based on answering those questions from PRAPARE. Your social worker should be able to do a care plan or an electronic care plan and an intervention or procedure that's represented on SNOMED CT. So CPT unfortunately isn't as granular or don't have granular codes for addressing SDOH. They're quite generic. But SNOMED CT has very granular or specific ways to represent procedures and outcomes for social drivers of health issues, such as on the right, you will see counseling for finances, education, and guidance has a specific SNOMED CT code, and food education, guidance, and counseling as well has its own code. Even SNAP has its own code. We want to support this because we believe that Prepare is your gateway to go through these process from one, again, assessment or survey, LOIN coded or SNOMED CT coded, with the health concern coded in a Z code or a SNOMED CT code, with goals, interventions, procedures, and outcomes. Also, again, you look at the quality measures on the very top here, number 4, is preceded by procedures and intervention and goals coded using the standards that we just discussed earlier. This is a very nice example of a fluid and security coding in an office visit. You start with a LOIN code on the top here, a screening for the hunger vital sign, has one specific code for that. And each screening question, for example, has, again, a specific LOIN code assigned to it. And for these questions, there are also LOIN answers represented. Again, you'll see it here in the middle, often true, sometimes true, never true. And then it cascades all the way to assessments and diagnosis, to interventions represented, again, in SNOMED CT usually. And then you generate an e-bill, usually using a CPT E&M visit, together with an ICD-10 CMZ codes. So you can see this kind of workflow happening. But I think what most people see is the ICD-10 and the CPT, and not necessarily the SNOMED CT codes or the LOIN codes. So this is my goal today, is really for you guys to know that, because it will help you get your PRAPARE data so that you can do your evaluations and all of your research, and you don't have to do any free text backcoding. You don't have to worry about normalizing unstructured free text. You can just use these machine codes to query your data and to check for quality. Because we all talk about quality, but we don't really address the root cause of bad quality data, which is unrepresented data, all in free text with misspellings and errors. Why do we care? This is a very recent release, just this month, is the US playbook to address SDOH. And it says here, you'll see wording, and I highlighted here the Gravity Project and US Core Data for Interoperability, or USCDI, that we just talked about. You'll also know that this is quite recent as well, that the administration has taken action to address SDOH, and that CMS released their physician fee schedule for Medicare patients or Medicare participating organizations, that they are, in their words, finalizing to pay separately for community health integration, SDOH risk assessment, and navigation services to account for resources where clinicians involve different healthcare support staff like community health centers, care navigators, furnishing the necessary care. So at least there have been payers who have been approaching NAC that to share that they have started programs where they are reimbursing social determinants of health screening and activities. I know of two. One here is in DC, PCA, and the other one is in the state of Pennsylvania. What you are seeing here, if you remember the Gravity Project earlier in the slide, that the Gravity Project has published value sets for SDOH conditions, goals, service requests, and procedures. And this is what they look like. If you go to VSAC, the Value Set Authority Center, hosted by the National Library of Medicine, you will see this value set with multiple codes, both on SNOMED CT and ICD-10-CM, that represents all different conditions, SDOH conditions, regardless of domain. I highlighted two things here, which are Z codes for homelessness. And if you'll notice the wording for Z59 and its children, it's homelessness unspecified, homelessness in the past 12 months, housed with risk of homelessness. But what we are missing in granularity are those that exist in SNOMED CT, such as housing instability due to being held behind payments or due to frequent change in residence or threat of eviction. So those kinds of interesting granular information or concepts are missed if SNOMED CT is not being utilized in your organizations. Similarly, for goals, you will see that most of the goals here, with a lot of information on their description, is on SNOMED CT as well. For service requests, a lot of the more granular requests are also represented in the SNOMED CT ontology and not on CPT or on ICD-10. Last but not least, this is their value set published for procedures. I highlighted two commonly used CPT codes, 96161 and 96160. You'll notice that it is not it's the CPT code for administering a risk assessment instrument such as PRAPARE, but it's not granular enough to separate it from other inventory such as depression screening with the PHQ-2 or PHQ-9 screening or other questionnaires. So if you query 96160 or 96161 in your database, you won't be able to easily tease out those that are PRAPARE-based procedures and not social determinants of health related screening assessments. This is like our ultimate goal really is to do all of these things automatically. So that's how you use your PRAPARE data. And the importance of this PRAPARE data is for you to, as folks who are getting this data, get this package into a FHIR to a FHIR resource and transmitted using the FHIR API to different organizations that are accepting that kind of messaging standard, which is again federally required. And the Gravity project does does this kind of work where they want to close the loop. You're seeing, let's start on the very top here, screening/assessment, again PRAPARE, represented using LOINC and or SNOMED CT. Going around for diagnosis, we use ICD-10, but again, I told you guys SNOMED CT has a more granular way of representing these. And then you go around, you go through LOINC, representing goals, going to SNOMED CT, representing granular interventions and not generic CPT interventions. How does this work and how do you use this? I think a lot of people want to use PRAPARE information, hopefully to populate their UDS tables. In this case, you are seeing a JSON FHIR code on the left that you'll see that code that's in purple or violet, and then with a colon, and that's the LOINC code specific for Native Hawaiian, and that's the LOINC code specific for non-Hispanic or Latino. So if you were going to populate your UDS table 3B demographics table, then it should be a no-brainer. You should just query, if you want to get that number, why can't you just query 2079-2 to get your population of Native Hawaiians? And likewise for any other thing. Similarly here, another example of a way to populate, for example, table 4. There's a way to package this using a FHIR code on JSON on left, and that would populate that specific part of your UDS reporting table. I guess the key points here is we want you guys to be able to progress in your advancement in data science using PRAPARE data through not just you guys, quality and data science personnel with the proper tools, but also, again, data standardization, which lends to data governance as well, ensuring consistent and reliable data handling by using standards that represent these concepts. When I say, again, standards, those are the machine codes that are unique for those concepts and not recorded as free text. And I'll show you that in a bit. This is generally what we have to do when we get data for our CDC projects. We have to map them to different target catalogs that you're seeing in the middle, and then create cohorts or groups of them through different managed value sets internally. Now, generally, we want to extract our data, PRAPARE data to provide meaningful information to multiple consumers. What you're seeing is Lego blocks of data. It should be an easy way to sort them. And an easy way to sort them, again, is by adhering to those standards using those machine codes, SNOMED CT, ICD-10, LOINC. Arranging them and explaining them with a story. But you can't really reach the explaining them with a story or visual representation if you have so much data quality issues and there's so much data cleanup to do. Here's a quick data challenge on SDOH. What you are seeing here are different data that we have seen multiple networks transmit to us, and you're seeing the free text extraction from their database. Birth country, for example, there are misspellings, country of origin, there's additional information that isn't really necessary. There's educational level in the right here. You're seeing like different ways, again, different free text ways of gathering this information. There should be an easier way or a structured way to represent all of these so that there's no data wrangling or much data cleanup to be done. So what we're going to try to do in the next few minutes, we still have time, I believe, is to do this kind of data mapping to terminologies. That's due to how information is inconsistently represented in much of the data you're getting in your electronic health record systems, and that includes PRAPARE. Whereas there's one, coded data is not available. Two, there's proprietary coding systems, for example, EPIC. You need to get the EPIC Clarity or EPIC certified analyst to understand or do some queries, and you can't just use an SNOMED CT or LOIN code to just quickly query your EPIC data, as I believe so. Last but not least, you have to wrangle hand-entered data. And not everyone is 100% accurate typists. That's generally not our job. But how do you handle hand-enter data with misspellings and, in possibly incorrect entry or abstraction? So let's take a look at this next slide, shall we? What you're seeing here are SDOH observations in multiple domains. Column B would be the source value in their database. You see they are represented using different display names or text, and they are not in any form of standardized machine code, such as NOMED CT or LOINC. You get the column C here, which is the survey question, most likely from PRAPARE. And you have, generally, you have to wrangle and see how you can combine all of these data to make them more actionable or create a cohort. So after mapping, you have to do this manually again. You have to do this kind of quality mapping for your data. You see column D has to be normalized to one specific value or variable name. Another one here is mapping, for example, SDOH data to safety or for safety. You see the observation name here in column C is their variable name in their database. Again, not machine represented using the standards. And column F, you're seeing here in the spreadsheet, the observation name or the answer to that question. And they're varying. So there's no, there's yes, there's only N, there's only Y to represent yes. There's no, there's unsure, and there's a quick free text to do it. And just really, you have to normalize them, just populate in column D. Is it a positive screener? Is it a negative screener? And all of that stuff. And generally, you'll eventually end up with different mapping files for each of the SDOH categorizations. But I think the first step really is to look at the crosswalk, the PRAPARE crosswalk. And number two, to see how your PRAPARE data is represented in your EMR. What you can do initially is ask your data analyst or ask your EMR vendor or your data vendor, can you show me what my SDOH PRAPARE data looks like? Get a sample extract. And I want you to take a look back at this presentation and check to see if they are using LOIN codes. Are they using SNOMED CT codes for these? Because again, those are federally required standards for representing SDOH data elements. Here's another example again, a mapping activity. You see the observation name on the second column. You see that's the normalized observation name, but you're seeing again free text or a variable name and not the machine code for the observation name in the source. And you do something similar where unknowns or answers to the negative of that SDOH tool, you have to put whether or not it's positive or negative. And again, normalizing terminology, normalization is quite important. These are just, again, sample SQL queries on how we did it at NACC. different categorizations. What you're seeing now is a normalized version of agricultural workers question from an acres questionnaire. And these are different SDOH categorizations from what we have been receiving SDOH-wise and housing status. So after we do this kind of mapping, data mapping from text to text, we categorize them next to the value sets that are published by the Gravity Project. Here's an interesting example of what you can do. For example, once you've done the terminology normalization, this is an example of housing status and COVID vaccination, for example. After normalizing for a while, it took a long while to normalize the free text housing status for the data that we received. This would have been a lot easier if we could just have used one single term or query or machine code to query housing status. Same thing with this. There are also specific concepts or single codes that represent federal poverty level and income levels as well. And then if you can easily query this kinds of concepts, SDOH concepts using machine code, using SNOMED CT or LOINC, then you'll be able to do easy cross tabulations or visualizations crossed with other clinical variables such as vaccination, stress, for example, here, and COVID vaccinations, for example. So what now? This is just a call to action for those who are on this call right now, is to leverage existing policy levers such as USCDI, 21st Century Cures Act, the HDI-1 proposed rule, and USCDI version 3. Because by the year, if the proposed rule, which will be final by the end of this year, will require your EHR vendor and all certified health IT products in the United States to support and adhere to USCDI version 3 and how SDOH is represented there. Don't reinvent the wheel. A lot of vendors tend to create their own screening tools that haven't really been validated possibly, or have no representation in open standards such as LOINC. Possibly they are representing their in-house or proprietary SDOH screening tool and make it available only to Epic or Cerner or NextGen users. That doesn't really support interoperability or the general cause of us creating local, community, regional, or statewide analyses of our SDOH data and make them actionable regardless of which state or where you are in the country. And lastly, if you have a data folks, or if you need support in normalizing or mapping to existing standards, there are terminology services out there that can help you, or you can contact us, the PRAPARE tool, the PRAPARE folks, and or the informatics team at NACC. This is what we want. We want to the current state, an interoperability nightmare, lots of mapping, lots of translation, to this future vision that we have using common data element implementations such as USCDI version 3 to create seamless semantic interoperability wherever you are in the country, whatever software or system that you use, those who are using PRAPARE, linking them to the standards and codes, and having all of those codes interact with each other seamlessly using a FHIR API or HL7 or whatever messaging standard that is federally required. Whew, that was a lot. And that's around about 50 minutes. Let's have a chat. I'm going to stop sharing and I'm going to check the chat to see what kind of questions you guys have for me. And please feel free to unmute and ask me a question directly. I'm going to stop sharing my screen, and I want to thank everyone for your attention from the very beginning. So let's look at the questions here. Chloe, are there questions in order?
Yeah, so actually, so the first question that I did notice was from Anita, and she said, curious why LOINC was selected standard for PRAPARE.
Yes, Anita. So LOINC was the selected standard to represent the PRAPARE instrument itself. That's because LOINC represents the survey instrument and the questions included in those survey instruments. So if you saw, so most, if not all, validated survey instruments that are used clinically in the United States and across the world is on LOINC. So if you look at your depression screening, that's on Loink. It's not necessarily selected as a standard. That's because it is currently the only terminology that has specifics for question and answer pairings, such as what you see in survey instruments or clinical measurement instruments, even again, depression screening and all of the other instruments that you've seen clinically. So that's why. Again, any survey instrument that you're using probably exists in PRAPARE. So if, for example, you have a digital health literacy or a literacy question or smart form, why don't you check Loink and see if it's there? I'm most likely it is there. And I saw an answer or response here from Colin. PRAPARE isn't really a billable procedure. That's absolutely right. PRAPARE itself is not billable, but the procedure for doing SDOH screening, there are movements now for value-based care, and other payers are starting to support reimbursement again for SDOH screening, not necessarily PRAPARE only. Loink isn't usually associated with lab values, but is in fact extremely comprehensive. I do have to say Loink is associated also with lab values. Specifically, it has normal values. It also states the unit of measurement. For example, if you're abroad using metric or imperial system, whatever your lab is using, there are specific Loink codes that mention that this is the lab that is represented using those UCUM units, grams per deciliter, for example, or using molarity measurements, stuff like that. So generally, Loink has those metadata in their codes. So great question, great response, Anita and Colin. Thank you so much. I see a question from Suzanne. Go ahead, Chloe.
So I was just continuing down the chat. And Anita also asks, does screening have to be completed by a medical provider to be reimbursed? There are many cases in which, go ahead.
Yes, great question, Anita. Sorry for interrupting you, Chloe. There are many cases where ancillary staff complete the SDOH screening. Yes, unfortunately, currently, before you can input or include an ICD-10-CM Z code into the problem list, because the Z code is part of the CPT billing, right? You have to put the CPT code and you have to list down all of the diagnosis ICD codes, including the Z code. That's what they require, and the only people that are legally allowed to input that in the EHR are the providers. So my recommendation right now, and I'm sure there are already talks to assist with other health center staff that are not necessarily providers to be able to input SDOH information, not as a part of the medical or clinical problem list, but as an administrative social information that can be addressed separately. But there are different ways of thinking about these things. But what I would do is, if you have staff doing the SDOH screening or PRAPARE screening themselves, is to maybe have a post-it or a note and put it on the chart so that the provider, you would have done the PRAPARE screening already, but then you're creating suggestions for your provider or your chronically burned out physician or NP to look at your assessment using the PRAPARE screener and see, oh, okay, yes, I need to put the Z55, Z56, Z57 on the problem list. I know a lot of providers don't really care so much to put it in because they're not immediately reimbursable, but we are gearing towards more acceptability or more reimbursement doing these kinds of things. Again, taking the burden away from the provider entry and really moving it to other staff who may have more bandwidth to do this. This is a complex topic, and I definitely understand where you're coming from. That is a really great question, so thanks. I do want to address this question by Suzanne. Is anyone aware of efforts to evaluate nutrition security measures in addition to food security? I would defer to the PRAPARE team. There are, again, different ways or different concepts in food security or hunger as the vital sign. My primary message here is that different questionnaires ask things in different ways, which means the answers also are semantically different. I could be food insecure in a way, not because I can't afford food, but I can be insecure in a way that I can only eat food and non-nutritional diet. That in other people can define that as food insecure or a diet that does not support a healthy lifestyle, for example. So again, great question, Suzanne. Any more questions, Chloe?
Yeah, so I did see Tara had I have two more questions. There's one from Tara and one from Patricia.
Of course.
And Tara stated, when a patient has a Medicare Advantage plan, should we be choosing Medicare still or private insurance? Also, why is Medicare still considered an SDOH for people over the age of 65?
Gosh, sorry. So thanks for the question, Tara. I believe that question on their prepare questionnaire is really, again, I think I had a slide for that, which is for medical insurance coverage. And I just want to quickly glance at the standard. So I do not want to give you incorrect information. Generally, what I do is put your data element name on Google and put USCDI afterwards. So I'm on Google, I put USCDI, I go to the healthit.gov website for US core data for interoperability. Look at coverage and look at the coverage types. So looking at the coverage types right now, let's see what's included. I can actually share my screen so that you can see what I'm doing, because I would encourage people who are working in quality to do this type of workflow or investigation as well. So we are at USCDI version for health insurance information. And it says here that these are insurance information used by hospitals. And these are examples of applicable standards for it. There's a profile, there's QDM guidance as well. And let's see what people are saying. So I do have to do some searching. I think I should follow up with you after the call. But generally, there are mapped values for these. I believe there's I could look at what value they are for this. So sorry, very sorry I wasn't prepared to answer this. Medicare Advantage. I have to read some more. Thanks, Tara. Are groups having success billing 96160 and 96161 for Prepare? Patricia, yes. So I've talked to DCPCA, DC Primary Care Association. They are specifically using 96160 and 96161 to represent social drivers of health or SDOH or that type of inventory or screening, together with the appropriate ICD-10Z codes. And their payer is Americaritas Health. So I think you generally have to ask who are the payers available in your community that you're partnered with to see if they are supporting this, because this is a case-to-case basis. But I will say yes, there are payers and health center networks or individual health centers who have had success using these two CPT codes together with a possible E&M code in conjunction with the Z codes and get reimbursed for them. So thank you so much. Oh, you're welcome, Patricia. Great question. Really, really great question. We do have 4 minutes left. 2 minutes, I'm sorry, because Chloe has announcements in the last 2 minutes. Wanted to open the floor for any questions. Please feel free to unmute or type your question in the chat.
Dr. Raymonde, this is Anu. I have a question.
Hi.
It was a really wonderful presentation. So I wanted to ask you, since we are already mapping some of the diagnosis codes that are applicable to some of these prepared questions.
Sure.
With that in mind, now you have the line code. So is it one or the other, or do we have to do both?
Yes. So a great question. So to represent the question itself and the answer that's resulting from the question itself, in the back end, they have to be represented using the line codes. And that just makes it easy in the back end so that your database knows that all answers or all questions that represent that concept, that specific question and answer pair is represented properly. For the Z code mapping, the Z code should be mapped to the answer to the question or the LOINC code that represents the answer. So for the Z code, for example, for homelessness, that's only a positive screening if their answer to that housing question is at the positive or positive screening, or yes, this patient is housing insecure. So that Z code should be mapped to a positive answer or a LOINC answer that is paired with that question. So LOINC only represents the questions and answers themselves. So the answers, LOINC answers, should be the ones mapped to those Z codes. Because if you mapped the LOINC question to the Z code itself without knowing the answer, then you might be mapping the question that may be a negative screening or the patient is not housing insecure to be part of your housing insecure numerator or your measurement. So I would say representing again the questionnaire is on LOINC, but mapping should be done LOINC answer paired to the ICD-Z code. And you have to be careful with the semantics also, again. And I think you will see some limitations also that some of the, if you look at strictly at the semantics of the question in PRAPARE and the answer pair, that the Z code doesn't necessarily grasp the full semantic concept of that's being answered by the patient or collected by the provider. That's why you heard me talk about SNOMED CT. And again, SNOMED CT is the required federal standard to in conjunction with ICD-10-CM to represent these SDOH concepts in the problem list. So the problems list now should be a combination of ICD-10 medical codes, ICD-10-Z social codes, and social and others using SNOMED CT. Does that answer your question? Do you have any follow-up questions?
Yeah, since you said that, see, for the LOIN codes, it's a lot easier to map to a lab test. So we know we can ask a lab vendor to do it, or we can do it manually. For all these questions, and how do we, because I see that you have answers for everything, a LOIN code for everything, positive, negative, the different types of answers. You have LOIN code for that. But how do we go about mapping and making sure that we have the correct LOIN code representing these prepared questionnaire?
Great answer. Great question, Anu. This is usually done by informaticist, a clinical informaticist, or terminologist, or a terminology service. But if you do have a person who is good at doing that data mapping, you have a data analyst or a senior data manager who knows these concepts really well. I guess one of the first things you have to do is talk to your vendor and first see if they are supporting LOINC mapping to your questionnaires, because most probably they are using Quest or LabCorp or your state lab to do that, because you just mentioned that for lab tests, blood tests, those are easily mapped to LOINC, but for questionnaires they may or may not be using a LOINC to represent those. I think that's maybe a limitation of your vendor. So my first step would be ask your vendor, hey, I need this map to SNOMED CT. I need to map a questionnaire to LOIN codes. Are you guys supporting it? Because you have to be supporting it. And if they are supporting it, ask them your next steps. So that's what I would do. So I would investigate first. I hope that gives you a solid action item or first step.
Thank you, Dr. Raymonde. Yes, that
please
helps.
Email me. Anytime. Let's continue the conversation. I know we're at the top of the hour. Please follow up with me, put in my email, and I'll hand it back to you, Chloe.
Thank you, Ray. Thank you so much for a great presentation. We always love when you join our sessions. With that, folks, I would like to remind you of a few things. So right now we have our Prepare Tiger team evaluation. We would like to thank you for your participation in the 2023 sessions, but now it's your opportunity to tell us what it is that you would like to hear. We would like to see what kind of content you would like for us to develop for you for 2024. So please take some time out and complete the survey. You could either scan the survey right over there, or I went ahead and dropped the link in the chat for you all, so please take some time to do that. With that being said, we also have our Prepare user survey going on, and the purpose of it is to gain a better understanding of Prepare implementation needs and experiences and challenges. Again, we're looking to find out how it is that we can better serve you. So please scan the QR code or go ahead and use the link in the chat. And then finally, our team at NACC, the SDOH team, we're hosting a health equity learning collaborative aimed at exploring how health centers are utilizing social drivers of health data, patient and community voice, and community partnerships to advance health equity. So, and on top of that, we will be providing some strategies, some promising practices. So please take some time out to apply for that. And the application closes January 26th. If you have any questions, please feel free to email me, Chloe Dastanoble, and my email is listed in there. Again, please feel free to scan the QR code or go ahead and click on the link in the chat. And with that being said, that is all that we have for you all today. Thank you for joining us today. Thank you again, Ray, for such an amazing presentation. And thank you all for your questions, and have a good one.